So now the PFM VSD coil today, actually it fits very nicely after this very easy case which went without any problems. But it fits, and you'll see that like we did few mistakes in decision making, and we'll talk about when we come to this area. So this is this VSD lay coil, and it's actually exactly like the PDA knit occlude coil, but the difference is that it has the bigger loops has filaments in it. So not the loops, all the loops have filament, but only the loops which go into the left ventricle have filaments in it. It was made because where the PDA coil, there was some complaints that it has a lot of residual leaks. But unfortunately, this caused other problem, unexpected, which was that these coils, if you leave them with a significant residual leak, will cause hemolysis. While the PFM coil, when you compare them with the detachable coil, they don't cause much hemolysis, even if they are left with a residual leak. Now, this is very important, I believe, which is during the procedure, any VSD procedure, we have to be very careful with keeping the ACT above 200 milliseconds. So you'll see us taking ACT, checking, giving more heparin and so on. This is very essential, especially when you do this young babies like the one we did today, and we had before problems with that if you don't stick to that. Now, there are different shapes of membranous VSD, and the coil is actually planned for muscular VSD, because if you do angiography, you'll find many of these VSD, they also have a conal shape, and the coil has this conal shape. And there is this perimembranous VSD with one outlet, sometimes aneurysm with 2, 3, and some are more complex, with even some defect which jetting directly towards the tricuspid left or right atrium. Now, patient selection is clear. Patient should have normal resistance and effective defect diameter. This is very important. So the diameter towards the right ventricle should be never bigger than 8 millimeter. And there is a reason for that, that this coil device has two different measurements from the right ventricular side, either 6 millimeter or the bigger devices like the one we use today is 8 millimeter from the right ventricular side. Distance to the aortic annulus should be more than 3 millimeter, and body weight more than 10 kilogram. And you see that in decision making today, we did few things we should not do. It's not true, because occasionally you can use this device even for 5 kilo babies, but you should be more at home with the like your surrounding, your support, and so on. But like today, we did 7.8 kilo. It went well, but it could have done also in the different direction. Now, so you see here, these are the available devices. This is from the left ventricular side. All this, so 8, 10, 12, 14, 16. And this is here from the right ventricular side. You see 6 millimeter, and the bigger one, 8 millimeter. And for this baby, we could have used 12 by 6, would have been more than enough. But I was afraid that having on this side a hole which is about 5 millimeter, I was afraid that this could flip through. But we ended, that's why I chose one with 8 millimeter. But we got stuck with having too big from the left ventricular side. Now, femoral access and the usual, it's exactly like if you did VSD before, it's the same. So you do your hemodynamics first. You do LV angiography, usually 50-20 LAO, and you define your VSD, you size it, you measure it, and then you cross retrogradely, and I go step by step. And then, of course, you do the veno-arterial loop, and you do what we did before, advance. I'll go step by step, but here first, the selection of coil. So the distal coil diameter equal or 2 millimeter larger than the base. So from the left ventricle, if you have, like we had here today, 10 or 11 millimeter. So actually 12, 14 is a little bit too big, obviously, but it is in the acceptable range. The reason for that I thought the aneurysm after coming from the left ventricle was actually larger than the entrance from the left ventricle. So that's just by pulling it more in, it will be situated completely in the aneurysm. And then from the what we coil deployment, so if we have perimembranous VSD, the coil is usually configured in the ascending aorta. Muscular VSD configured close to the septum. And of course, the reason for that being it's a coil and you could get stuck with the mitral valve apparatus if you go too deep into the left ventricle. And on the right ventricular side, 1 or 2 loops are usually enough. So the angio, showing here the VSD, not so well, but it's clear. And then you have the TEE guidance. Sometimes you can even work with thoracic echo. It can be enough. We see here the VSD in the aneurysm. Sorry for that. What it's occasionally nice is if you from the start use a wedge balloon catheter, advance it to the pulmonary artery, and it's very important to use a 15 millimeter snare to catch the wire while you develop the venous arterial loop. Because 15 millimeter is usually the size, even in adults, of the pulmonary artery. So you just open the snare. When you cross the VSD retrogradely, you end through the snare, and you don't have to look for it everywhere, especially if you don't have biplane. Now, this is here crossing. Usually we use Judkins Wright, 4 French, or a cut pigtail to cross the VSD, and this is the wire. In tiny babies, I rather use a soft wire, like here in this case, Terumo 35J. In older children, it's recommended to use a stiffer wire so it helps you. Okay, then the next one. So this one already, when you see this is the jump. So they developed the coil. And I mentioned also during catheterization, you watch these 2 things. One, the distance between the tip of the sheath and the tip of the delivery catheter, 1 centimeter. The other thing is, you see the coil, it's lighter here and gets much darker here. This is the part which is enforced. So the coil go reverse. And when it jumps here across the aortic valve, today it didn't jump. And the reason was also a decision problem, because the tiny babies, and remember here the recommendation is above 10 kilo. This is 7.8. Of course, the aorta is also smaller. And I think the 14 millimeter is almost as big as this aorta, and I think that's why it was not easy to retrieve it back inside the LV. Here it jumped, you see, and the beauty is it falls immediately into the aneurysm. Occasionally, you have, of course, to, if you are stressed a little bit, you might do a mistake. When it jumps, you pull more, and suddenly you are in the right ventricle. So you have to be careful with that. Now an angio is done to secure that the coil is in place. The interesting about it, actually sometimes you can do it without echo guidance. It's not recommended because at least at some stage you have to be sure that you did not damage the aortic valve and did not damage most of all the tricuspid valve. Because the tricuspid valve with a coil, you can catch some of the chordae and then you will end having significant TR. Now this looks nice, and then the next one, releasing the coil. And I showed you the mechanism is quite easy. It's actually only like you pull it back from, this mechanism is like the wire inside the coil, and you pull it out of this coil, and it ends like this. Nice position. And then, of course, you do the angiography. In this case, also, you have some residual leak. As I mentioned before, some residual leak is acceptable, and usually you don't find any hemolysis with it. The problem is if you leave more than this, and actually it's also after Implantation device, when you release, there is always some residual leak. Now, this, you have to click on this, please. Okay. This is now in a 7-kilo baby, the angio done in the left. Repeat, please. Here you see very nice aneurysm, and already we crossed here into the pulmonary artery with this cutter. Now the next, click it, please. Now the coil is in place and almost no residual leak. There are people who, and there is here some residual leak here. And some people, they don't like the appearance of the coil. I understand that, because it protrudes sometimes too much into the right ventricle. But if you do an echo over, you don't find no stenosis anywhere in the area. So really the only biggest concern is not the protruding. The biggest concern is damaging tricuspid valve, causing tricuspid regurgitation. Now here this is still frame from mid-muscular VSD, and you see the conal shaped. Actually, this we've done long ago with a normal PFM coil. So it did work, but they stopped using it because this coil in VSD position had a lot of residual leak, so it really didn't make sense at the end. Now, one issue, very controversial, and Tronc-Philly is like pushing ahead with his colleagues in Asia, because they have a lot of these, they call it doubly committed VSD, or the Japanese type, or we used to call it subpulmonary, infundibular, whatever. So this is the patient where we'll have also aortic valve prolapse. And we know, I think everybody of you in his institute, her institute, will have problems with decision-making when to operate on these children. And of course, we tend, if the patient is 4 years old, prolapse, having already some aortic regurgitation, we would send for surgery, reluctantly, because the patient is completely asymptomatic, but we know it's a sort of prophylaxis. Now, Tronc-Philly and his friends, especially in Vietnam, they asked themselves, why not put a coil instead of opening the chest? And this, what they did, and this still frame, and you see here the prolapse of the aortic valve, here also, and you see already the prolapse, and we see already the pulmonary valve. Of course, we know that the subpulmonary VSD we see actually best in the short axis view, because unlike the perimembranous, the VSD is heading by 12 o'clock. We cannot see it here well. I'll skip that. Well, if I can, yeah. Here, this is the coil in place, and after release, again, somebody told me this is too much in the RV, but believe me, you should not worry about this. You should only worry about having TR. Now, this is a presentation presenting like experience from different countries in, I think, 300 cases. He mentioned that somewhere. Sorry for that. Wait a second. And this, sorry, I do mistakes. Yeah, these things were analyzed, and we checked also for hemolysis, of course. 303 patients from 12 countries. This is the age range up to 120 kilo, very difficult, and then most of them perimembranous VSD, and almost 19% subpulmonic VSD, and few muscular. Now, success rate was 94%, and the reason for failure of 6%, which is almost 16 patients, I think, is all this. Like, he didn't have the right device size, poor configuration of device, what almost happened today, but happily it did not. And embolization of the device also happened, and of course, unstable rhythm. Now, death didn't happen. This is good. We have detachment in 5%. And I want to look at this here, like 7%. This is quite high. And this definitely, as I said, is related when you leave too much shunt. And so obviously, if you have a device leaving a lot of shunt, either you retrieve it or you put a bigger device if you leave it many times, because you don't know exactly which child will develop hemolysis, which not. But definitely, it's worrisome. As a matter of fact, the company is working on this to attach this filament in a different way. So obviously, there is a way to avoid this hemolysis. Now, clinical results are complete in like 2/3 of the patient. And this is what we should look at. Happily, no severe AI. But tricuspid regurgitation, trivial in 8%, but 6% mild, is worrisome. So we should always make sure to see in the different views that the aneurysm is really not attached to the tricuspid valve, but because part of developing of this aneurysm is by the tricuspid valve itself. So occasionally you have really to avoid this coil and put something else instead. If you fear that, like Mansour and me, we did one together where actually with trunk feet together, that we said, no, this is too much next to the, you were also involved with the TE, this is too much next to tricuspid valve, and if you are afraid this might damage, you take it seriously, what we took, so we put another AS01, I think. No obstruction to RVOT. Now, here we looked at these patients with, I think you have to click again, with this subpulmonary VSD, so 35% of the total group, 87% were technically doable. Now, the issue is here, when you do this, you know that you have to look and to know what happened to the prolapse and to the aortic regurgitation, because I have a patient with a trivial aortic regurgitation with a VSD, you close the VSD, and you don't want them to have worse aortic regurgitation. So the AI did not progress, unchanged in 56%, but the good news, regressive in almost half of them. So there might be a chance here to treat these patients like this. But I don't think we have long-term enough experience to say it's recommended. But at least some people are looking into that. I think it could be important, because if we have something without opening the chest which can cause regression of the AI, this would be perfect. Now, this here slide, like they're looking at how much residual leak exists, and amid some categorizing. Of course, we have to be honest. I'm closing very fast. 1-2 minutes here. That we have to be honest. At the end, we need a device which closes 100%. There is no doubt about that. Now, this here, we put like complete closure and trivial leak, 91%. So, but the truth is, complete closure after 6 months or over 6 months, up to 6 years, was, let's say, 80%. So this is a problem. That obviously we have some who is definitely higher leak than the Implantation device. But the only good news, click on this, that in case you have a residual leak, you can position another coil inside. Click again, please. Another coil inside here. Next one. Yeah, and then click again. And then you can reduce the residual leak or abolish. So there is this chance, but obviously after, let's say, 6 months or so. Now, this is also very important, because we know the study presented from Milano, Dr. Carminato and colleagues, suggested that using the perimembranous VSD device and occasionally the muscular device, that will have AV block up to 4%. So this device here, actually, no AV block until now. Doesn't mean never exists. But I think it could happen as long as you position the device inside the aneurysm and not attached to the aortic valve. Conclusion. Intervention closure VSD using PFM VSD Coll is safe, effective for a selected group of patients. PFM VSD Coll is the first choice for the closure of perimembranous VSD smaller than 8 millimeter. In VSDs with complicated morphology, PFM VSD Coil seems to be better than competitive devices. Surgical intervention closure are complementary. Thank you very much.